All right, good morning, all. Welcome to Grand Rounds, our first of 2021. Hope everyone is so far having a good year. To be determined for most, I suspect. Hearing none, I'll turn it over to our neonatology colleagues for the NICU updates. Thank you.
Okay, good morning, everybody. This is Steph Komic. I'm just pulling up my screen real quick. Okay. All right, can you all see that?
Yes.
Oh, perfect. Okay. So for those of you who haven't had the chance to meet yet, again, I'm Stephanie Komic. I'm one of the second year NICU fellows. And today I was going to go through two cases with you all. We can stop and have some questions after each one is fine. So with that, let's get started. All right, so the first case I have for you all is a 29-year-old G4P2012 at 37 and 1 weeks with a due date of 12/28 who was referred to MFM for fetal findings on ultrasound concerning for osteogenesis imperfecta. Her serologies for the outside documentation were negative. Torch panel had been done at her OB's office that was significant for IgG positive for CMV and IgM positive for toxo, but her torch titers are otherwise negative. Her pregnancy was significant for ultrasound findings concerning for OI, fetal growth restriction, fetal hydrops, and polyhydramnios. She otherwise just had hyperemesis gravidum, where she was requiring a Reglan pump, and then iron deficiency anemia. Her other chronic medical history was just significant for asthma, and then she notably does have a history of postpartum depression with prior pregnancies. Two of her previous pregnancies were low transverse C-sections at 38 weeks, and she does have a history of a spontaneous abortion with her second pregnancy. Her medicines are listed there. She did receive 2 doses of betamethasone in November. The details regarding that, though, I couldn't find in the outside records. So this is a summary of the ultrasounds that were performed from the referring physician. Her ultrasound in September showed a shortened bowed appearance of the long bones with multiple deformities of the long bones consistent with current and or healed fractures. There was stippling of the calcification pattern of all the bones seen, or long bones seen, and then a small thoracic circumference suggestive of mild pulmonary hypoplasia. Lamellar bones were noted to be normal, and baby does have club feet and polydactyly. Estimated fetal weight in September was below the 10th percentile. And then for her subsequent ultrasounds from the referring OB, she did develop polyhydramnios in October, and baby's weight continued to be low, measuring below the 1st percentile for her October and November ultrasounds. So she was first evaluated in MFM on December 8th. Again, the detailed ultrasound performed that day showed the long bones again appearing short and abnormally shaped with sharp angulation suggestive fractures. The baby had visible femur fractures as well as a possible skull indentation, the occipital and parietal bones, and fetal hydrops was noted with edema of the skin of the abdomen and the thoracic regions. She additionally had polyhydramnios. An estimated fetal weight at that time was in the 4th percentile. 2 days later, mom did present to L&D in active labor with a bulging bag. Bedside ultrasound confirmed breech presentation, and so a level 2 C-section was called. Baby's age at that time was 37 weeks and 3 days. AROM was at delivery. APGARs were 3, 6, and 8. NICU was present. Baby did receive CPAP, FiO2 titrated as needed, and she was transferred to the NICU on CPAP, PEPA 5, FiO2 at 21%. And birth weight was 2620, which is the 21st percentile. So her admission physical exam, I'm just going to go over the highlights in blue here. So she was known to have a large boggy area in the back of the head with what felt like bone outlining the area. Sclera were notably white. Respiratory wise, she was in moderate respiratory distress requiring CPAP. Some subcostal retractions were noted. Musculoskeletal wise, she did have spontaneous movements of her limbs. Her hands did have bilateral postaxial polydactyly with a total of 12 fingers, 10 toes. The right leg was flexed to the hip with the toes pointing inward towards the right ear. Her left leg internally rotated at the knee, and she did have shortened arms and legs with bilateral club feet noted. Here's her initial x-ray. So again, just focusing on the blue here, there was notably an acute mid-diaphyseal right humeral fracture, which y'all can see here, as well as deforming of the right femur with abnormal curvature right here. And then cortical irregularity with hyperplastic callus formation of multiple ribs and femurs, or in the left femur. So you can start to see, I'm not sure if y'all can see my mouse, but there's some little notching on the ribs that you can see from previous fractures. So for her care, baby was admitted to the NICU. She was deemed NPO originally and placed on IV fluids. And we did get multiple services involved. So on day of life 1, orthopedics and endocrinology were both consulted. Ortho recommended a skeletal survey and obviously very careful handling. But at the time of admission, there was no need for an acute intervention. Endocrinology agreed with ortho's recommendations and then additionally suggested further workup for skeletal disorders and metabolic bone disease. So she did get some nutrition labs. Really here, I think the biggest note from those labs listed was low vitamin D level for what she was started on vitamin D. And then Dr. Chan recommended genetic testing for metabolic bone disease. And then at a later date, once we had some results back or baby was stable, to perform a DEXA scan and hearing screen. So looking at her bone survey, I'm just going to kind of go through the different images. The chest showed, again, normal or numerous bilateral rib fractures and bowing of the scapular bodies. Her skull radiograph demonstrated osteopenia without radiographically visible fractures. And then there was notably numerous compression fractures throughout the thoracic spine with varying degrees of height loss, as well as cupping of the vertebral end plates at multiple levels. The left upper extremity showed a healing proximal humeral diaphysis fracture, as well as a healing radius and midshaft fracture and bowing of the ulna, and then a healing fracture involving the first and second metacarpals, which aren't seen very well in this picture. And then the right upper extremity, again, confirmed the displaced humeral shaft with the healing fracture of the radial shaft, and then bowing deformity of the ulna. Left lower extremity showed a healing fracture of the midshaft of the femur, and then a non-displaced transverse fracture of the distal tibia and proximal ulna, as well as bowing of the long bones. And then last but not least, her right lower extremity showed a healing midshaft fracture and marked bowing involving the midshaft of the femur, proximal tibia, and proximal fibula. So I'm not going to go through her. I'm just going to give a summary of the hospital course. We have it here for reference. So CNS-wise, she did get a cranial ultrasound on admission that was normal. She does have a cranial helmet that we are using for protection. We've gone over the skeletal survey. Her pain management initially was largely controlled with scheduled morphine. She was then transitioned to Tylenol and hydrocodone, and now is currently on Lortab Q6 with morphine PRN. CV-wise, she has been stable. She did have line UVC placed for fluid administration originally. Respiratory-wise, again, she was admitted on CPAP. The team was able to wean her to a nasal cannula by day of life 4. However, baby did start to show some increased work of breathing on day of life 19. And so she was placed on high flow. She currently remains on high flow at 4 liters per minute. Her FiO2 titrated to maintain gold SpO2. FENGI-wise, she has been worked up on enteral feeds and is currently on full NG feeds. I know at one point speech had been working on her with oral feeding, but she was having some difficulty. Human ID wise, her labs have been stable. Her hematocrit is a little low. She is currently on iron supplementation. And then ID wise, she has not required antibiotics. Musculoskeletal, we've gone through the skeletal survey. Ortho is still following at this current time. We're really just using everything we can to keep her comfortable, including like Z-Flow pads and just really comfortable bedding as much as we can to help her. So endocrinology is also following this baby still. We are still waiting on her genetics to come back, and once that's done, we'll consider scheduling her for her DEXA scan. Until we have a confirmed diagnosis, endocrinology wants to wait on initiating bisphosphonate therapy. Genetics wise, again, we're waiting on the skeletal dysplasia studies to come back, but her karyotype was confirmed to be female. And then family is continually updated, and palliative care has been involved as well. So what I want to talk to y'all about today is osteogenesis imperfecta. So really the focus of this, as you'll see, there are multiple, and probably know there are numerous types of osteogenesis imperfecta. And so what I wanted to focus on are the ones that we can see in utero with ultrasound prior to birth, as here in NICU. So OI.
Okay, I got it now.
Okay. More casually known as brittle bone disease, inherited connective tissue disorder. We've learned about this in medical school. There are many different types associated with multiple phenotypes. The spectrum of OI is extremely broad, ranging from forms that are lethal in the perinatal period to mild forms in which the diagnosis may be equivocal in an adult. So the epidemiology, overall, the incidence of OI is fairly rare, estimated to occur in about 1 in 20,000 births. The autosomal dominant forms of OI are equal in all racial and ethnic groups, whereas recessive forms occur predominantly in ethnic groups with consanguineous marriages, obviously. What we are concerned about today is specifically regarding our patients. So looking at the pathogenesis and how OI happens, we find that, we do know a lot of the reasons why OI occurs. So it's most commonly caused by mutations in the gene encoding for the alpha-1 and alpha-2 chains of the type 1 collagen, or of the proteins involved in the post-translational modification of type 1 collagen. So if you look at the picture in the upper right-hand corner, you may recall that collagen type 1 is composed of tropocollagen, which is the structural unit. And so it is this tropocollagen that's the product of procollagen, and that's where the alpha chains are involved. You have 1 alpha-2 and 2 alpha-1 polypeptide chains. And if you remember, type 1 collagen is involved in bone, tendon, ligament, skin, and sclera. So that leads us to many of the clinical findings that we see. So, when we think of OI, we think of the blue sclera. Other things we think of are the atypical fractures, opalescent teeth, short stature, scoliosis. Then some other things that may not pop up originally, but we need to keep in mind depending upon the type of OI that the patient has, are basilar skull deformities, which may cause nerve compression or other neurologic symptoms. Remembering the Warmian bones, which are small irregular bones along the cranial sutures, hearing loss from damage to the ossicle bones, and then increased laxity of ligaments and skin and easy bruising. So most patients with OI do have an autosomal dominant mutation. Again, it's the alpha-1 chain or the alpha-2 chain in the COL1A1 or 1A2 genes. The severity of the clinical presentation depends on the effect of the specific mutation. So as an example, for type 1 OI, mutations in the COL1A1 and 1A2 lead to simply a decreased amount of normal collagen. So that's why with your type 1 OI, you might have a more mild presentation. In contrast to type 2, which is our lethal form, the mutation is in the same genes, leads to a disruption in the actual triple helix of the type 1 collagen formation. So you have an actual defective collagen. And then for type 3, which is severe, and type 4, which is a moderate form, the mutation here results in defects within the collagen structural proteins. So I think it is worth noting, too, that COL 1A1 and 1A2 are not the only genes involved in OI. In fact, these genes are normal in approximately 10% of cases. Many patients with those normal genes have are more likely to have an autosomal recessive type of OI, which for the sake of this presentation, I'm not going to go into today. So OI can be diagnosed in two ways. Obviously, you have your clinical findings and your lab findings. And so a lot for at least types 1 through 4, the silence classifications are how you can categorize OI. Otherwise, other things that can be used are histologic distinctions or molecular defects noted within the collagen itself. And so here for this slide, I wanted to take a look at the types that we can see perinatally. So type 2 is your first picture, type 3 is your middle picture, and then types 7, 8, 9, which are grouped when you read about them, is the third picture there. So for our patient, her presentation, which unfortunately I was unable to get permission to use her photo for this presentation, but we believe she categorizes more in the type 3 OI picture, which is consistent with the findings from the fetal ultrasounds. So for type 2, this is your perinatal lethal type. Infants may be born stillborn or die within the first year of life. Their birth weight and length are small for gestational age, and there's extreme fragility of the skeleton and other connective tissues. There are multiple intrauterine fractures of the long bones, which have a crumpled appearance on radiograph. And there is striking micromelia, which is small extremities, and bowing of the extremities. The legs are held and abducted at right angles of the body, more in like a frog leg position. Multiple rib fractures create a beaded appearance, and the small thorax contributes to respiratory insufficiency. The skull is large for body size and has enlarged anterior and posterior fontanelles, and the sclera here are dark blue-gray. The cerebral cortex has multiple neuronal migration and other defects. So there can also be agyra, gliosis, and periventricular leukomalacia. Type 3, so the middle picture, is the most severe non-lethal form of OI and results in significant physical disability. Birth weight and length are often low normal. Fractures usually occur in utero, and there is relative macrocephaly and triangular facies. Postnatally, fractures occur from inconsequential trauma and heal with deformity. There is disorganization of the bone matrix, resulting in almost like a popcorn appearance of the metathesis, and the rib cage does have can have flaring at the base, and pectoral deformities are not uncommon. Virtually all type 3 patients have scoliosis and vertebral compression, which we saw that our baby did have, and growth falls below the curve by the first year. And so the scleral hue ranges from white to blue. Our patient was white. And then should she grow, dentinogenesis imperfecta, or the opalescent teeth, is something that happens. And then these patients also are more prone to hearing loss and scoliosis over time. And then the third picture, so this is your type 7, type 8, and type 9. These are all autosomal recessive types of OI, so they're different from the COL 1A1 and 1A2 gene defects, and tend to overlap. These types tend to overlap with types 2 and 3, but with distinct features. So these babies do have white sclera, rhizomelia, small to normal head circumference, and surviving children do develop osteochondral dysplasia with extreme short stature. Type 9 is particularly very rare, with only 8 cases reported, and severity ranges widely from lethal to moderately severe. Again, with the laboratory diagnosis, DNA sequencing is the first diagnostic laboratory test, and there are several panels that exist to test for dominant and recessive OI. And then, and this is important because a specific mutation can help with, one, clarifying the diagnosis, and also can help with family counseling. So morbidity and mortality of OI is largely cardiopulmonary. So if you think about it, the baby's already at a disadvantage with a smaller rib cage and some pulmonary hypoplasia, and then with easy fractures and pain that's associated. Recurrent pneumonias are common, as well as declining pulmonary function. Cor pulmonale is something that can also be seen. This is usually later in life and more towards with adults. Neurologic complications can also be present too, especially with the basilar skull invagination. So you can have the basilar invagination, brainstem compression, hydrocephalus. Most children type 3 and 4 do have this basilar invagination, but the brainstem compression is uncommon. And then, so our goals of therapy for the patients with OI are to reduce fracture rates, prevent long bone deformities and scoliosis, minimize chronic pain, and maximize mobility and other functional capabilities. This is definitely a multidisciplinary approach and includes multiple specialists, so genetics, endocrine, ortho, neurosurgery, plastic surgery, pulmonology, optho, developmental peds, making sure these babies stay on track, dentistry, and then also your therapies, your PT, OT, and speech. The PCP is also essential, and having a medical home is definitely ideal. For the pediatrician too, is paying close attention to how the baby develops, the neuro exam, growth and head circumference, making sure they're getting their regular hearing screens and lung function screens and cardiac screens. As far as therapy, so bisphosphonates are the mainstay of pharmacologic fracture preventing therapy, with pamidronate recommended for patients with all forms of OI and whom the clinical benefits are likely to outweigh the potential long-term risks. So these are with patients with long bone deformities, vertebral compression fractures, and greater than or equal to 3 fractures per year. So our patient definitely falls in this category. And then regarding the prognosis, obviously both lifespan and functional levels are affected and very important. So infants with type 2, if they do not pass in utero, usually die within the first few months to 1 year of life. Patients with type 3, so where we think our patient falls, she has a reduced life, will likely have a reduced lifespan with clusters of morbidity with morbidity with pulmonary causes in early childhood and the teen years, but they do have a life expectancy up into their 40s. These patients are generally wheelchair dependent. And then regarding the other types we spoke of, 7, 8, and 9, it's relatively unclear. The spectrum's pretty broad, just given that we don't have too many known cases. And then here is just for reference, just to kind of give an idea of the numerous types of OI, their inheritance gene, the severity, and some of their clarifying features. So does anybody have any questions at this point, or I can move on to the next case?
I have a comment, Steph. I don't think this child's going to have a normal life expectancy. When you look at OI type 3, there's really a bimodal distribution of survival for these patients. There's children that survive past age 10 that do have a normal life expectancy, a reasonable life expectancy, I should say, and then there's patients that succumb to their illness prior to age 10. She's in a severe form with her lung restriction. You know, both Dr. Holcomb and I, have been on service for the past couple of weeks, have seen that it seems, while it's possible that we may make progress of weaning her off of the high flow oxygen support, I'm not convinced we're going to, given just the severity of her presentation, the amount of fractures that she has, her thoracic deformity. It's described as time moves along. The scoliosis typically is the issue that leads to thoracic insufficiency. That doesn't usually happen until, children are 6, 7, or 8. But I think in her given case, the fact that, the initial COT that we got was 70, I don't want to be overly pessimistic. It's still early in her course, but I think there's reason to think that it may be difficult to wean her to support that would allow her to get home, and that we, may have challenging conversations ahead with this patient.
Yes, thank you. There has been a few meetings with the family already, and I think some of those ideas have started to be introduced. So yes, thank you. Anyone else?
I just want to make a comment about this patient's referral to MFM. As you saw from the review of her outside records, this diagnosis was made at the time of her anatomy ultrasound in her private OB doctor's office in Aiken. The patient was then sent to an MFM out in the community in South Carolina, who followed this patient essentially her entire pregnancy with this known diagnosis of osteogenesis or suspected diagnosis of osteogenesis imperfecta. This definitely sent us scrambling at 37 weeks when we were asked to possibly urgently deliver this woman by repeat cesarean section, being that she'd had several prior sections and had presented to the outside hospital with preterm contractions. I know I'm preaching to the choir, and I know that we're all kind of on the receiving end of, cases like this, which are definitely exciting and unique and great learning opportunities for our, students, residents, and fellows. But I was definitely less than thrilled about the last minute, again, referral to us with all of this kind of going on and having been known. Cases like this, I think, when we anticipate that outcomes are going to be difficult and that, outcomes are going to be poor and that conversations are difficult, it's nice when we're able to meet with families and establish a rapport with, with patients. I think it's unfortunate that in this case, that was not really able to happen before this patient delivered. So that's all I have to say.
Yeah, I have a comment also. It was there, I might have missed it. Was there any other family history of OI is the first question.
No, there was not. So
Okay.
Mom, it was asked, she said that, short stature is really the only thing that ran in her family, but she had no known family history of OI or other skeletal issues.
Okay. So, the genetics of this is extremely important in discussing with the family what the recurrence risk is. Is this a recessive recurrence risk with a risk of 25%? Or is it, an autosomal dominant? And so, understanding which gene has pathogenic variants is going to be critically important. So I would guess, so they probably checked for type 1 and the type 1 or 2 or 3 in this first panel, or do they do all of these? I would think you would at least do the panel by next generation sequencing of a targeted panel. That would be easy to do all 16 of these on a panel, but they might do a reflex test. Like if it's 90% type 1, 2, 3, then if that's negative, then move on to the panel of the others. And with confirmation by Sanger sequencing.
Yeah.
So what did you tell her the recurrence risk is, or how would you approach it based on what you've said?
So for this mom, I'm hoping that we do have the panel back sometime this week, and I think that will really help us in counseling her. So if the baby does have an autosomal dominant mutation, that would be something that we would have to counsel her on, that, it is likely for this to occur with future pregnancies. And then if it is autosomal recessive, obviously the chance is less, but, I would definitely have her seek further genetic counseling if she decides to have future pregnancies.
Actually, the risk is higher if it's autosomal recessive. There's a 25% recurrence risk.
Mm-hmm.
If it's dominant, you're looking at, the parents are unaffected. So
Right.
could be gonadal mosaicism, which would usually people quote a 2 to 4% recurrence risk for dominant diseases like that. Which brings up one other question, is there increased paternal age? Because that's known to be associated with point mutations in autosomal genes. So looking at the paternal age would be good to look at. And one last comment, that this is the type of disorder where a missense variant is more severe than a deletion. So you showed the collagen, the heterotrimeric folding of it. And if you have a missense variant, it's going to affect folding and screw that all up and usually causes a more severe phenotype than a deletion.
Okay. Thank you. Okay. All righty. Well, with that, I appreciate all the comments and questions. So we'll move on to the next case. So case 2. So the initial MFM consultation was on November 16th. This is a 23-year-old G3P2 at 33 and 1, referred to MFM regarding multiple fetal anomalies, including fetal gastroschisis. Mom did receive her previous care at her private OBs outside of Augusta. Maternal prenatal labs, so serologies were negative. Mom did have a history of gonorrhea and chlamydia earlier in the pregnancy. And then her pregnancy findings were significant for fetal gastroschisis, ventriculomegaly, thickened trachea, scoliosis, arthrogryposis, and bilateral club feet. NIPS and amniocentesis were performed with normal karyotype and microarray per outside hospital documentation. Mom is an alpha thal carrier. And then otherwise, she had no chronic medical history, had 2 previous healthy pregnancies, and is on no medications. So the fetal ultrasound that was performed that visit showed herniated bowel with the cord insertion not visualized. There was noted abnormal curvature in the thoracic and lumbar spine, hyperextended fetal neck with abnormal feet and toes. And then the baby was notably growth restricted with normal umbilical artery Dopplers. Brain images were reportedly normal with no ventriculomegaly noted. And the estimated fetal weight at this time was below the 3rd percentile at 33 and 1. The recommendations at that time were consultation with ped surgery and the NICU, as well as a cardiology referral for a fetal echo. And then the plan was to continue to follow mom with serial ultrasounds every 4 weeks and weekly antenatal testing. So weekly BVPs were performed, and mother was notably did develop mild polyhydramnios around 37 and 1, with estimated fetal weight remaining below the 3rd percentile. The echo was performed on December 10th, and results were did show a structurally normal heart with some thickening of the aortic valve leaflets, mild RVH, and trivial and reversal noted in the ductus arteriosus. P's card recommendation at that time were just to repeat the echo once the baby was delivered. So on 12/27, mother presented to L&D with spontaneous rupture of membranes, and she was admitted for delivery. So baby was born at 39 and 0 via spontaneous vaginal delivery. NICU was present at the time of delivery. APGARs were 1, 6, and 8. Baby was brought to the panda bed. The abdominal contents were wrapped in plastic wrap. Baby initially had no spontaneous respiratory effort, and so PPV was started. The NICU team did attempt to intubate, but failed, and so PPV was continued with response to the heart rate and SpO2. Baby was later converted to CPAP around 4.5 minutes of life, and then FiO2 titrated to keep stats in goal range, and then baby was transferred to the NICU on CPAP +6 with an FiO2 of 30%. The measurements weight was 2170, which is below the 1st percentile. Head circumference was 32, about the 2nd percentile. And given the baby's positioning, which I'll get to at the physical exam, it was difficult to obtain a birth length, and so there's not one documented. So the general appearance, so again, focusing on the blue. So the baby was notably hypotonic with dysmorphic features and gross deformities and appearing small for gestational age. Proptosis was noted bilaterally with mildly reactive pinpoint pupils and with inability to visualize the red reflex through the small pupils. I do think it's worth noting here that given the gastroschisis and the emergent consult for pediatric surgery, and the baby may have already been started on morphine for sedation and pain control for surgery at the time of this exam. And so that could explain some of the pinpoint pupils. GI, the abdomen did show intestines protruding, a 3-vessel umbilical cord. Musculoskeletal wise, so there were gross deformities of the arms and legs with hands, arms, and legs contracted bilaterally. The hips were internally rotated and legs and feet were pointed, cephalid with club feet bilaterally, 10 fingers and 10 toes, and no diaphragm. Neuroexam showed, again, general hypertonia, and GU was male genitalia with a small scrotum with testes not palpable in the scrotum. This is the baby's initial x-ray. So the baby was intubated upon arrival to the NICU in preparation for surgery for silo placement, which the baby did tolerate well. Additionally, baby was started on D10W for IV fluids and empiric antibiotic therapy, given the gastroschisis and need for surgery. So we can see the ET tube is in good place. There are myogranular lung markings, and then just visual upper and lower extremities. Osseous structures are seen, and so the evaluation of them individually is limited, just given the positioning. So day of life 1, again, it was definitely a multi-disciplinary approach. Orthopedics was consulted. The findings showed bilateral congenital knee dislocations, left club foot, right calcaneovalgus foot, and then bilateral upper extremity deformities and contractures of the shoulders and elbow. They recommended PT and OT and positioning the baby as passive range of motion allowed. And then, given the silo placement and everything that was going on at admission, said that they would evaluate later regarding further management. ENT was consulted, given the difficulty with intubating the baby, and a flexible laryngoscopy was performed, which showed just some mild granulation and edema consistent with the recent intubation attempts, but otherwise normal anatomy. And then ophthalmology was consulted, who actually came and saw the baby yesterday regarding the poor red reflex. And then what was later noted with the proptosis is the difficulty of the baby being able to shut his eyes completely. Their ROP exam was zone 0, or stage 0, zone 3. And then they do have concern for cranial nerve 6 and 7 function at this time. So we are currently applying lacquer lube to the baby's eyes to keep them moist every 2 hours. So hospital course, just overall, but in brief, so the cranial ultrasound was performed on admission and showed no IVH or ventricular megaly. Morphine was used as needed for postoperative pain. And then again, the lacquer lube is being applied to the eyes. Respiratory wise, baby was admitted on CPAP, intubated for repair or for silo placement, and then subsequently again for repair, after which he was just weaned to CPAP and is now currently on room air. Cardiovascular wise, we did do an echo on admission that was significant for a PFO and PDA, but no other structural concerns. UVC was placed on day of life 1 due to a PIC being unable to be placed just because the baby was difficult to position appropriately for a PIC placement. So a Broviac was placed when he went for his closure of his gastroschisis. FENGI, the baby was deemed NPO. OG was placed to low intermittent suction, and he remained that way until after his repair on day of life 4. He continues to be NPO on TPN, and G is now to gravity. Heme-wise, he's been stable. ID-wise, he's only required antibiotics for his surgical interventions. And G, we did do a renal ultrasound that showed slightly smaller kidneys, but otherwise normal, and a scrotal ultrasound was performed that did find the testes being in the inguinal canal. Musculoskeletal, again, we're following ortho's recommendations, and we'll continue to follow with them as baby course progresses. Endo is stable, and we did send a karyotype, which is 46XY. We're currently talking with Carolyn Lavelle with genetics about what other testing would be appropriate for this child. So I wanted to spend a little bit of time talking about arthrogryposis. So, it's arthrogryposis, you have contractures, right? So it involves the muscles that are replaced partially or completely by fat and fibrous tissue. Congenital contractures are generally thought of, it is often used as a shorthand description for multiple congenital contractures that affect 2 or more different areas of the body. So The term arthrogryposis really refers to a symptom complex, not a specific disease process. And you can see this being associated with greater than 300 different disorders. The prevalence for arthrogryposis is about 1 in 3,000 live births. Inheritance, natural history, and treatment and outcomes are largely defined by the underlying disorder if present. So, which is why determining the specific diagnosis in each child is important. Though I think it's also worth noting that arthrogryposis can be sporadic as well. So looking at the classification, so to establish a differential, it's important to first decide whether the child has a normal neurologic function. So if the neuro exam is normal, we think more along the lines of amyoplasia, a distal arthrogryposis, or generalized connective tissue disorder, or fetal crowding. And if the neuro exam is abnormal, this indicates that maybe the movement in utero was diminished as a result of abnormalities of the nervous system, the motor end plate, or the muscle. So for our baby, with the exception of the cranial nerve findings from ophthalmology, his neuro exam is otherwise normal. And so we can kind of categorize more in the amyoplasia. So amyoplasia, if you break the name down, it's no muscle growth. So this is a classic syndrome that we think of when we think of arthrogryposis, in which there are contractures involving both the upper and lower extremities. Amyoplasia accounts for about 40% of all children with multiple congenital contractures. The cause is unknown and appears to be sporadic. And so at this time, it's largely a clinical diagnosis. Etiology and pathogenesis is currently not known as well, though these children with this disorder have been found to have a decreased number of anterior horn cells in their spinal cord suggestive of a neuropathic origin, and then there are some concerns for vascular origins given some of the other anomalies that can be associated. So looking at clinical features, so these are just some general pictures of amyoplasia. So you'll have adduction and internal rotation and contractures of the shoulders, fixed flexion or extension contractures of the elbows. Looking at the wrists, you can have rigid volar flexion and ulnar deviation, or dorsiflexion radial deviation contractures. The thumb, there are thumb and palm deformities, and it can be rigid interphalangeal joints of the thumb and fingers. Flexion and abduction and external rotation contractures of the hips with dislocation of the hips can also be present, and our baby's hips are dislocated. And then the fixed flexion or extension contractures of the knees with severe rigid bilateral club feet. Many of these patients can also have a mild facial hemangioma. These patients do largely have normal intelligence. And it is worth noting there is an association with abdominal abnormalities, including gastroschisis and bowel atresia. So I was able to get a hold of this mother, and she did allow me to share a picture of her baby. So here's our patient with and this is post his closure for his gastroschisis, but you can see the deformities and how they compare to the previous slide. So there is, though the cases are found to be sporadic, there is an increased prevalence with twins and in conditions that would lead to decreased limb movement. So bicornuate uterus, oligohydramnios, interuterine crowding. For treatment for this baby, the goal is really mobilizing the joints and applying splints for improved position and function, and continuing to provide physical and occupational therapy. Long-term morbidity, so most children require therapy into their teenage years, and surgeries may be required for persistent limb deformities and to improve function. And the goals of long-term treatment are largely similar, with increased joint motility and muscle strength, and to develop adaptive behaviors and to use those to allow for independent activity. As for the prognosis, in the newborn period, it's not uncommon for these babies to require some sort of respiratory support or nutritional support, or feeding support, I should say. But generally, they find to recover well from that. And though the prognosis does sound grim, and there are a lot of associated complications, there some of the studies I looked at did show like a relatively good long-term outcome, with one study reporting as high as 85% of children developing the ability to walk and perform activities of daily living. It is worth noting, though, that as the child grows and if he enters adulthood, assistance with activities of daily living are will definitely be something likely in his future. So for him, he has come a long way. Hopefully we'll continue to start with surgery, follow with ped surgery, and see how we're able to progress his feedings, and also with ortho on what the next stages should be to help him and help increase his mobility. These are my resources, and with that, I'm happy to talk about this baby too. So, any questions? Any comments or questions?
Hearing none, thank you so much, Dr. Komic. Those are extremely interesting cases. I will remind everyone, I unfortunately had to jump off the meeting for just a couple of minutes for an ambulatory meeting. Just reminding everyone to just be as safe as possible. I think that whether it's you're getting your information from your department or from your peers or colleagues, or even the local news media, I think everyone's very aware that the situation is becoming extremely dire as it relates to our staffing and our ability to care for patients in our usual manner.